Are you ready to go all in?
Let's do this. Let's do this. Let's do this.
And welcome to the All In Practice Growth Podcast. The podcast brings you a new and a different perspective on the dental and medical industries. I'm your host, Shane McElroy, and I'm so excited you're joining me today. A little bit bummed that the U.S. lost their World Cup game to Belgium, but hey, we're not supposed to win anyways, so whatever. 4th of July was pretty good. Hope you had a great 250 celebration for the U.S. of A. And before we get going with our guests, a quick reminder here, Blake McClellan, my business partner, and I will be speaking at Bulletproof's AI Day, which is August 9th. But you want to go to the Bulletproof Summit. Phenomenal if you want to learn all about the business of dentistry, how to scale. For people who've already done it, like Dr. Peter Bolden, Dr. Craig Spodak, and many, many others. Their third day of their conference of the Bulletproof Summit is going to be all AI all day, though. Please come and see me. Go to the whole conference. But if you can't make that, they set it to be standalone. So here's a little code for you guys. You can save 20% on Bulletproof Summit or on just the AI Day. So if it's AI Summit 26 and that capital S on the Summit part. So if you can be there at the Phoenician in Scottsdale, Arizona, August 7th through the 9th, well, you get to be with me, and that'll be awesome. And you get to learn how to do a lot of cool stuff in AI that I still am trying to figure out how to do. So that should be a good time. But excited to introduce our guest today. I've known him for a number of years. I spoke to his study club before. He's a periodontist out of Washington, D.C. He's been published. Loves Back to the Future. We'll get into that a little later. Loves soccer. We're going to talk a little bit about World Cup. And then we're going to talk about a bunch of dental stuff too. So I'm excited to welcome to the podcast, Dr. Armin Abron. Dr. Abron, thank you for joining me on the All In Practice Growth Podcast. How are you?
Good. Thanks for having me.
Of course. You know, when did we meet? Maybe it was like 3 years ago? I think I spoke for your study club, right?
Yeah, I believe it was 3-4 years ago. We met in Washington, D.C. We came and spoke to our referring doctors regarding digital marketing and topics that are more relevant these days and how to market yourself in the practice and social media.
Hey, look what we're doing now. So that's crazy. All right.
Exactly.
So was I the best or the worst you ever had?
Probably the best we ever had.
Okay, good. Because I think you had Blake McClellan there too, my business partner.
Yeah, I don't think he can come close to you.
Oh, yes. We have it on recording. I'm going to send this directly to him. Checks in the mail. So
Right.
well, before we dive into it, because I've been watching the World Cup. U.S. had a really hard loss, but I want to ask you some questions about that. I know you're a soccer fan, or football. Can you give everybody a little bit of high level background where you're from? How you got to being a periodontist, kind of that truncated version.
Sure, absolutely. Yeah, originally, some of the interest in soccer comes from growing up in Europe. I grew up in Germany, and when I was 17, my family moved to North Carolina and finished my high school there, my last year of high school. And that's kind of why I attended the University of North Carolina in Chapel Hill for my college. And while I was in college, I became interested in dentistry and wanted to strengthen my interest in dental school and started doing a lot of research. During that research, I actually got exposed to placing mini dental implants in the rat tibia. And so as a sophomore in college, I was doing microsurgeries per se. And that's kind of how I got into surgical aspect of dentistry. That's how I became interested in implants and attended dental school also at the University of North Carolina in Chapel Hill. And while I was there with the interest and the background in implants, I wanted to further my surgical skills. And that's why I went and did a 3-year residency in periodontics. And I attended Columbia University in New York. And after those years of education and residency, I wanted to be in a private practice setting as I was very passionate about the clinical aspect of dentistry and periodontics. And I practiced in private practice in North Carolina for 3 years. And having lived in New York for a while, it had changed me a bit. So I was trying to find an in-between, somewhere that would kind of be between New York City and North Carolina. And settled in Washington, D.C. in 2008. And I've been here since then.
You kind of nailed it. Like, D.C. is definitely going to be the
not just
middle
geographically,
ground.
but just also lifestyle-wise. I mean, we kind of have a nice mix of both urban lifestyle per se versus suburban lifestyle or rural area here as well. It just depends how far you drive out or away from DC.
Oh, 100%.
Yeah.
100%. All right. So a lot to unpack there. We'll get to that in a second. But like I said, I was devastated watching the US. I was like, oh, this year's our year,
Yeah,
right? We
absolutely.
look amazing. We're playing Belgium. We got a chance. And then we didn't have a chance
Yeah,
at all.
at all,
We got,
unfortunately. Yeah, I think we were a little bit intimidated by the big name, and I think we definitely had the potential and have great players, but I think it was that classical fear of a big name or a big country that unfortunately made us not play our game, and we set back and kind of
oh,
lost
yeah.
our focus, and I think that's what happened. Yeah.
Well, they lost it early. They gave energy late,
Yeah,
right? But
right.
the early
Yeah,
part,
too late.
it didn't
Yeah,
look good. And that one goal,
yeah,
when the goalie came out, that was
yeah,
embarrassing a little
yeah. But it
bit.
gave us some hope. So for what's to come, hopefully.
All right. Well, in honor of the World Cup, I want to play a little game with you, if that's okay.
Sure, absolutely.
All right. So we're going to do this or that kind of World Cup edition with Dr. Abron
Sure.
here. I'm just going to give you choices, and you don't get to choose other choices. You got to choose one of those two. So you ready to roll?
Sure, absolutely. Let's go.
All right. This is this or that World Cup edition with Dr. Abron. Okay. Bigger upset, Norway beating Brazil or England beating Mexico in Mexico, down a man most of the game?
I would say Norway beating Brazil because Brazil is always expected to win. They have the history. Norway has no history, so I think that was, even though maybe a little bit expected, but that's a big surprise anytime Brazil loses. So.
Yeah. Speaking of that game, this Haaland is in this question, so he's been
Right.
fun to watch. He's a beast.
Right.
I've never seen a Viking play soccer before,
Yeah,
but it's pretty
big guy.
cool.
Yeah.
More exciting to watch play, Kylian Mbappe, Erling Haaland, or Lionel Messi?
I'm gonna go with Mbappe. He's a young guy. He's fast. He's technical. It's exciting to watch a player grow and potentially become the GOAT. You never know. So we'll see how far it goes. He's very young. So
He could do it though. He's amazing.
yeah,
All right.
absolutely.
Same three players. Which player will win the Golden Boot this year? They're all tied. Mbappe, Haaland, or Messi?
That's tough. I mean, Messi looks hot right now. I think maybe between Messi and Mbappe. I'm gonna go with Mbappe just because I expect France to come far.
Yeah, I think France is going to have a chance to play the most games. Let's just be honest. They're pretty darn good. Okay, more handsome, Christian Pulisic for the USA or Cristiano Ronaldo for Portugal? I know what my wife chooses.
Yeah, I mean, you're asking the wrong person, but I'm sure my wife would choose Ronaldo as well. Yeah.
All right, last question. Who's going to win the World Cup? France or somebody else?
France looks too strong to get beaten, so I'm going to go with France.
Well done. You did really well here. So that was our honoring World Cup edition right there. So thank you for playing along with me. Now, you're in DC. We're recording this kind of just after the weekend from the 4th of July, which was our country's 250th anniversary. What was it like in DC for that celebration?
Hot. It was extremely hot weather, and that may have hindered a few folks to leave the house, including us, our family. But it was very festive. I mean, they had a few celebrations and events that they're scheduled. I mean, the city went through a bit of a revamping and cleanup and making sure it's presentable. So it's been very beautiful and nice here. And definitely you get the feeling that the city was celebrating something big, and is, because it's a event that's going to carry itself for a few months. So definitely exciting times to be here. Lots of events, lots of activities.
It's funny how when eyes are going to be on them, kind of like San Francisco or even Atlanta down here. Everything gets clean real fast, but that's only for that very short period of time.
Yeah, absolutely. Yeah, we don't see the usual things that we normally see in DC as much anymore. Not the last few months.
Okay, now we're going to get into kind of the dental side. I've always had this question of like, how does one even think to become a periodontist, right? So answer that for me. So take me through, you go through dental school and all that, how do you get into that particular specialty? So
you go through 4 years of dental school after college, and during that 4 years, some of us start thinking if I want to do something beyond general dentistry or not. And with me, it kind of started with my exposure to research and having done a lot of dental implant research prior to actually getting into dental school and getting published on those topics. So when I got finally into dental school and got to the point that I had to kind of decide where life takes me, what my path looks like, I became more and more interested in the surgical aspect of dentistry. So with that, you either had oral surgery or periodontics as a path to take. And periodontics offered the one specialty that was surgical oriented, but also offered a bit more variety than just, maybe other traditional surgical specialty we do. We are involved in gum grafting, dental implants, bone grafting, extractions, a number of cosmetic procedures, a number of procedures that create a variety and not very much a monotonous practice life. So kind of the surgical interest and kind of furthering my education and just kind of also the desire to be good at a very narrow area of dentistry was a driving factor.
Very cool. So, all right, we're going to get into a little debate here, right? And I'm going to pretend like I'm an oral surgeon. Bone is important because that's where an implant goes, right?
Absolutely.
Now, as a periodontist, what you're going to say is, well, what's more important, tissue or bone?
Yeah, well, both are important, but we like to grow the bone where the implant is going to be placed the most ideal location, because you want to make sure that implant is useful. It's going to give the patient the most aesthetic, cosmetic outcome. So we don't want to just place the implant where the bone is, but we want to grow the bone where the implant ought to go to give us the best long-term result. But both are important, tissue and the bone. And as a periodontist, we have the capability of creating that nice soft tissue contour architecture around an implant as well, because the gum or the soft tissue is going to actually make an implant look beautiful.
What do you go a little deeper there? Why would the tissue matter so much with an implant?
With an implant, but because sometimes, over time you can see some bone resorption, bone loss around implants. And many times, we see implants that were placed in the 80s and 90s. Sometimes the metal gets exposed and it takes away from that aesthetic outcome of the implant. So with creating that proper soft tissue contour, that we can achieve multiple things. A, prevent bone loss long term. We can prevent or delay recession in those areas. But also when a patient smiles, there's a lot of research on this. When patients or people look at a patient's smile, or your friend's smile, or family members, the gum is kind of what gives those teeth a nice contour, nice aesthetics, and gives you that aesthetic or cosmetic look of that person. So beautiful gum is actually what really long-term matters.
So it's kind of like the frame of the implant in a sense, the aesthetic frame, right?
Exactly, yeah.
Okay, now I'm actually going to ask a question for you because I do have a periodontist here. Okay.
Sure.
And I have, listen, don't judge me here. I live in the South. I dipped for a while. Okay. I'm just going to admit it. Hopefully my wife doesn't hear this. She'll get on me. And I had some recession near, like on my lower canines, right? Where I dipped, right? Like
that typical area. Yeah.
Yeah. So I lost, I don't know, maybe a couple millimeters there. At what point, right? Because you don't see it on me. Like I don't show that when I smile or anything. But I do have relatives who I know they've never dipped, but the older they got, what causes that recession? I kind of get it with dipping. It's constricting blood flow, right? But what causes most gingival recession?
In general, with gum recession is multifactorial. There are 3 components that as adult patients, we can maybe implement to prevent or slow down the recession. Those 3 factors have to do with grinding, clenching. So if that applies, you definitely want to ask your dentist to look into a night guard for you and making sure it's a custom night guard that's being made, or occlusal guard that we call it. Another point that's brought up very often is not brushing hard. So not scrubbing your teeth the wrong way, just definitely being informed what proper brushing entails. Electric toothbrushes are great for that because they kind of do take the control out of our hands. And I was jokingly said, well, you paid for the brush, let it do the brushing for you. So that kind of minimizes the trauma that we cause on our gums. And lastly, just maintaining good gum health, flossing, brushing that keeps your gums strong and prevents recession. But I mentioned at the beginning of the answer, it's multifactorial. So anatomy matters. Genetics, of course, is always plays a role that can be a predisposition. And also orthodontic treatment, unfortunately, with braces and Invisalign, sometimes the way teeth are moved, they leave us with thinner gum, thinner bone, and that long-term can also result in recession as well.
Now, I tend to notice it on people like getting it on their lower teeth more. Is that more common, or is it just that I personally notice that more?
Yeah, so with the lower teeth, definitely the tissue is thinner. So they can be a little bit more susceptible to recession in general, but also with the lower front teeth, those are the ones that most commonly experience most of the movements and root repositioning during orthodontic treatment. So we do see that a lot, unfortunately, post-orthodontic treatment, but also anatomy tends to be thinner in that area, i.e. the gum and the bone.
Okay, so I'm not gonna lie, I'm thinking about my aunt right now. She's got really bad gingival recession. Sorry, I'm not gonna say your name. But what can you do? Like, can that be, I know it can be repaired in some ways. Like what are the options for repair there?
Yeah, unfortunately, there is no alternative to gum grafting. Many times we see folks getting bonding on those roots to cover them up, which can help with cosmetic issues. It can help with sensitivity as well, but it doesn't really address the etiology or true cause of the problem. So some of us, including myself, have thin gum, so which make us a little bit more prone to recession. So by just placing a white filling on the root and making it look better, it doesn't take away the potential for that gum to continue receding. So as periodontists, being biased the way we are, we like to grow that tissue back that used to be there once before, and trying to also with thicker gum tissue, prevent further recession down the road rather than doing the bonding. Beyond those two options, there's really nothing else that's there to mask recession or repair recession. So gum grafting at this point is our main option left.
So what goes into gum grafting? Is that like harvesting your own tissue, which probably not everybody's like, oh, exciting, right? Or can you use like, pig tissue or other,
thankfully, compared to, decades ago, we have more options now. So up to 1985, we had only one option, which was going to the patient's palate or the roof of the mouth and obtain more or less a piece of tissue and transplant it to where that recession is. So since that decade in the 80s, things have changed a bit. In terms of the technique, how we obtain the tissue. So we can still, up to today, obtain the patient's own tissue for repairing gum recession. The technique, the way we do it, has changed. So back in the day, we ended up taking the tissue, resulting in a lot of discomfort, a lot of pain and bleeding because we kind of left the patient with an open wound. We don't have to do that anymore. There's different techniques that are available to achieve that repair with the patient's tissue, but leaving the patient with an easier recovery. Early 90s, we started using donor tissue. To be very frank, it is a cadaver donor tissue that we use instead of the patient's own tissue. That makes it easier for the patient's recovery because they don't have a second surgical site that they need to recover from or to heal from. So that has become very, very prevalent these days as an alternative to your own tissue in some ways, very much preferred by a lot of practitioners to use that as a solution. And thirdly, kind of in the last decade, we have had the pinhole technique, which if implemented in the right areas with the right architecture and anatomy, it can be successful as well. But these days we have those three options available to us as compared to the 80s and early 90s where we only had one option available, which was the patient's palate.
Now you said pinhole technique there, and I'm not gonna lie, I've been in dentistry a long time, and everybody's talking about pinhole, but I was in implants, right? So I'm like, well, if it's not ripping out a tooth, I don't care that much.
Yeah,
right?
not interested.
So tell me what I was pretending to understand for so many years, like, oh yeah, pinhole. Right. What is the pinhole? What is that technique? How is it different?
So to break it down and simplify it, as compared to using the patient's own tissue and with the traditional technique, it's a much more atraumatic or easier solution for the patients in the sense that there is no incision made. The gum is not being pushed back. You essentially, as the name already says, you create a little pinhole, a little hole in the gum tissue, which is very, very small, extremely conservative. And through that, you feed a lot of collagen sheet that's bovine derived underneath the gum line. And if you can imagine, if you feed collagen or material underneath the gum, it makes the gum thicker. And also, let's say, hypothetically talking about the lower jaw, it pushes the gum tissue back up. So that's kind of what a pinhole solution is. It's a way of adding more material under the gum to thicken it and changing the vertical height of the gum tissue.
Very cool. We're going to make fun of myself a little more now. And same thing with LANAP. LANAP for those who don't know.
Yeah.
What is that? Is that the same thing as pinhole or is that something different?
Yeah, so it stands for laser assisted new attachment apparatus or solution. So it's actually an implementation of laser that's being used to address the infection or disease of the bone around the teeth. So a bit different than addressing recession. It's actually addressing the problems at the foundation of your teeth, which obviously is important to maintain your teeth long term. So this was introduced in early 2000s in our field as an alternative to traditional gum surgery and bone grafting. And what it does, it implements laser to go around the teeth in the pockets, the deep pocket that are present as a result of bone loss, to essentially create a sterile environment by removing the diseased tissue, but also creating a sterile environment around the teeth, and it leaves the body to repair itself and regenerate itself, to attach the tooth again, with forming a new bone and new attachment of the gum to the tooth.
Okay, cool. Now I understand. I should have just asked this, a couple of years ago from you, and I wouldn't have to pretend like I knew what it was. Now, you mentioned earlier you were published.
Yeah.
I'm not that smart. I went to UGA. Nobody's publishing me,
Great
right?
school.
It's a great football school.
For sure.
Right. So how do you get published? What goes into being published? Like, how do you even do that?
Sure. Yeah, essentially. So if you're involved in research, when your research does have a new findings that has not been proven or has not been spoken about much in the dental community, you can submit your results by writing a paper and submit it to scientific journals. And it's peer reviewed, of course. And if it's significant enough that it contributes to the general dental community knowledge, then it's being published in one of the scientific dental journals. So I was fortunate enough to be involved in some of these projects early on that had to do with dental implants. And we were fortunate enough to get published myself through 3 publications in those scientific journals.
So how many more than one?
I think it's 3 official publications, and of course there's manuscripts and other items that get published, but the 3 papers are the main ones.
Well, la-di-da, right? I got 0, you got 3. But I have some funny TikTok videos, so
that counts more these days.
All right, let's get into an area that I do love, right? So I want to talk about full arch implants, right? Specifically, some people call all-on-4, which would be 4 implants. Smile Today, I think you guys called Smile Today. That could be a different number of implants. So I think people get confused. They hear all-on-4, but it's not really on-4. It's just it's phrasing, but that a implant company created years ago, but it really doesn't, it's for their brand technically, right? So how do you determine in a full arch case, you need at least 4 implants? I guess there's some opportunities people would say you need 3 in Europe, but here in the States is usually at least 4. How do you decide how many implants you're going to put for a single arch?
Sure, absolutely. I think my determination has a lot to do with what's going to provide the patient with the most long-term result and also best use of the prosthesis. So I also like to think long-term because, as we know, implants are great. They have 94, 96% survival/success rate based on 35-year studies. But we all know that sometimes some implants, not a lot, but few numbers, can get bone loss and be compromised. So my thing is always, if the patient has anatomy, meaning enough bone, I like to provide them at least a few more, at least 6, if in some cases 7 or 8, depending on the patient's size, biting forces, and so on. So, and also, I guess to answer your question more precise, it has a lot to do with how much anatomy or bone they have available. But if you have the option to provide them with more than 4, I'd go for that, and in every single case, just because, God forbid, in 20 years, one of the implants is not functioning well, we like to have the option for the patient to still maintain the prosthesis, even if it's -1 implant. And if you have 4, like you said, when you get to 3, it becomes a bit questionable. It's like having a stool on 3 legs versus a chair on 4 legs. So we just like to plan ahead.
So let's talk about some of that stuff. So full arch, why do you love doing full arch case? I know I loved it. I love it because the transformation of confidence I see in people, more so than even the physical. Yes, that's dramatic and cool. But for me, it was always in those cases, like they go from this hiding their smile to look at me. But in particular, like, no offense, Doc, you're a researcher. I'm going to go at your periodontist. Some people consider that nerdy. I don't know, with respect.
Some way it is.
What is your favorite part of those cases?
I think it's that transformation. I mean, just the fact that somebody comes in with not a lot of confidence about their smile, the fact that a lot of the patients are compromised with the chewing ability, their nutrition is compromised, items that they can eat is not their first choice. So the fact that patients, in some ways, somebody actually defined not having teeth as being actually handicapped. Sometimes somebody comes with that type of handicap to you, and the fact that you have the capability and skills to help a patient in those circumstances and making them more of a normal functioning when it comes to their eating habits and eating and healthy habits with regard to nutrition, that is very much empowering. Having the ability to help someone, it makes you feel really good in that. And there are other factors such as the cosmetics, the fact that they smile big, they're happier, they're more full confidence, they look better. Those are just all absolutely great aspects of this treatment option.
So for your full arch implant cases, right, where somebody has no teeth, you might replace, and you're going to replace all their teeth with implants, and they're probably going to leave that day with fixed teeth. Who is the average patient? Is it somebody who's already in dentures, or is it somebody who has like a few teeth left? Like, who's the average person? Because I think a lot of people think it's for denture patients.
Yeah, to be honest with you, there is really, in some ways, no average patient. When it comes to age, or any kind of economic or social background, it's really not any particular type of patient that you expect to walk through your door. It's pretty much anybody that hasn't had the fortune of having good oral health and has gotten to a situation where the chewing ability is compromised, and they're just looking for a solution to kind of get back on track. And sometimes this solution means getting a full arch rehabilitation done. So I would say anybody who has the ability or the skills to get more education, more information, and wants to do better in the future, that's kind of your typical patient who appreciates that type of work to be done.
Very cool. Now, one interesting thing, I've been in a lot of these full arch cases, and I noticed those with like diseased or failing teeth. As soon as those teeth were extracted, right? Like even though you're going through a procedure, you would think they would feel not as well as they came in, right? Because your body's recovering. But most of them actually, especially with like failing teeth, I feel better immediately. Why is that?
Well, you go from extremely compromised functioning, i.e. chewing and so on, to a very presentable prosthesis. So as you know, when you get the extraction done, the implants done same day, you walk away with a new prosthesis in your mouth. Even though it's not the final prosthesis that's going to eventually look even better, but the aesthetics that offers, the chewing ability that offers is already a tremendous improvement. It's almost 0 to 100 for those patients. So the fact that they're able to walk out with that prosthesis, with the function that they're going to enjoy with the next meal, it's 100% improvement to what they had before. So a lot of patients are already at that point very thrilled. And once everything heals more, we have the option of going back and providing them with even better final prosthesis. So I think that's why they just feel better right off the bat.
So one other question, do you place ceramic implants at all?
We place ceramic implants, not as much. There's some concerns about the longevity and so on of ceramic implants, but we do have the capability in some patients who are looking for metal-free, in quotation mark, implants. Ask for those implants, and we provide them in this office.
And is that more just because the request, or they theoretically could have a metal allergy? Theoretically,
yeah. There's some patients who do have some allergies that they're concerned with, and they're looking for a metal-free solution. And we position our office in that shape that we can provide that option to the patients. But it's mostly patient-driven, yeah.
So now I'm going to ask you a question on a theory that I have. I don't really think it's a great theory, but I think there's something there, right? So, how people say like eyes are the window to the soul, right?
Right.
I think that the mouth is the window to your overall health, right?
Absolutely, yeah.
And I'll have you've researched this. You're a doctor. You're going to give us some science and evidence here. But my thought process is this, and this is kind of evolutionary, right? So if you see a lion and they have bad or rotted teeth, they're not eating, they're done, they're dying, and nobody wants to mate with them. I think it's the same thing, right? You see rotting teeth. Yeah. Yes, it's aesthetic here, but I think more so it's more of like, I think our brains go, if that looks bad, then inside's got to be worse. What is the connection between oral health and overall health?
Yeah, the one obvious thing is good oral health allows you better function, better nutrition, healthier habits. As we are, as a population, learning more and more about good eating habits, we realize that, how important vegetables and fruits are and how we want to avoid ultra-processed foods.
Not corn syrup?
Yeah. So, but if you're compromised, unfortunately, those are the type of foods that you're going to gravitate to. More ultra
Yeah.
processed food, more softer items. So, i.e., less vegetables, less fruits, and so on. But one important, so that's kind of the obvious thing out there. Why a healthy mouth or health is important, because it's the gateway to your body. What you put in your body comes to your mouth. But there's a couple other things to consider. I mean, it's been proven back in the 90s how bacteria in the mouth can affect diabetes and how it
Mm.
can affect your systemic health. Pregnant ladies showed low birth weight for the newborns and also preterm labor as well. So those are very important aspects to be aware of. But one thing I realized on an individual basis when I started early on practicing in North Carolina, I was close to actually was working at more or less a retirement community where we had a lot of retirees from the Northeast retire down there, which is because it's beautiful, nice weather. I mean, you're in Georgia, the weather is a little better than where we are here. So
Uh,
sometimes, yeah. So one thing I realized is that a lot of these older ladies and older gentlemen, they're part of these country clubs or different social groups, and when they wanted to get together with their friends, they got together in these locations to eat together. So that's when I realized how important teeth are, because as we age, we don't go on that long bike ride or we don't go for a next hike because most of us, have some hips to worry about or some knees that just were replaced. And I realized how much of that social activity is surrounded by food. And in order to be presentable and to be functional, to eat properly and eat with your friends, you have to have good functioning teeth and oral health. You can't go to the next social setting and have your denture kind of coming in and out. That wouldn't be presentable. That would be embarrassing. So you would kind of socially retreat. So I realized how important it is as we age to continue maintaining our good oral health. So we end up being in a position that we can still continue our friendships, socialize with our relatives and family. So that's something I learned early on in my career by practicing down in that retirement community.
100%. So my mother-in-law, that was kind of the last thing for her because
Yeah,
she had a denture forever. She was born in Ecuador,
yeah,
lost her teeth at a very early age, right? And it was going to be a big procedure, but she couldn't go out to eat with her friends anymore because
yeah,
she would have to take her denture out to
correct,
eat. So
correct,
she had
yeah,
lost tissue, bone, all of that, right? And it was shifting around.
exactly.
But you're spot on there. It doesn't. It's not like you can just hide this all the time, or like
Yeah,
that is the social vibe, especially as you get older, right?
right.
You and I, like maybe I try to play soccer for a couple of minutes with my kids, but I'm probably going to pull something. I'll
Right.
meet you at the bar to grab a beer or some
Yeah,
food or something, but you don't go out like you did with your kids and hang out that way. It's just not the
yeah.
same thing. So I think
Yeah,
you're
we go as
spot
far
on.
as saying as the older we're getting, actually, the oral health becomes even more important. As we're young, we have other means to compensate maybe for lack of oral health. But as we get older, it becomes more and more important.
No, 100%. Well, we're almost out of time, but I want to close this out the right way. And word on the street is that John Small, who we both know, told me, is that you like the movie Back to the Future. Is that correct?
Sure, yeah, that was kind of my childhood movie. I
Mine
enjoyed
too,
time
right?
travel, and as a 10 or 11 year old, whenever I was at that age,
Well, by the
it
way, what
was
intrigues you about
awesome.
time travel?
Just seeing what we're going to develop into, where this world is going to go and what direction we're going to go. That's exciting. And we all have a lifespan, so I like to be able to maybe look beyond my lifetime and see where Earth is going to be, where technology is going to be, what direction we're going to develop.
So, that being said, is Back to the Future 2 your favorite, where they go to the future?
They're all great, but yeah, that's one of my favorite actually. Yeah,
Because you want a
just
hoverboard too. Let's just be
yeah,
real.
yeah, exactly. Yeah, we didn't
All
have
right.
that
Well,
back in the 80s.
I know. I didn't have. I
Yeah,
always wanted one. I
yeah,
thought we'd have one
yeah,
by now.
yeah.
I have been the. I've been Marty McFly for at least 3 or 4 Halloweens as well. Being I'm
Nice.
the same size as him, so that always.
Yeah,
My dad's got really white hair, so he's Doc,
yeah.
and it's long hair.
Right. Nice. Yeah.
Uh, so one my favorite movies now. My kids love them too. So we're gonna close this out
Same.
by playing a little Back to the Future trivia. Are you
Uh,
ready?
sure. I haven't watched
Let's.
it recently, but yeah.
Well, jump in the DeLorean, go back
Yeah.
in time, and then let's see how
Yeah.
much you know. All right.
Sure.
So this is Back to the Future trivia with Dr. Abron. All right. So what year is the original Back to the Future set in?
1985. The initial one. Yeah.
1985 is
Yeah.
correct. You
Yeah.
nailed that one.
Yeah.
Well done. Okay. What's the name of Doc Brown's dog?
Einstein.
Nailed it.
Yeah.
You do know these movies. You do know these
Yeah.
movies. All right. Question number 3. What's the name of the dance that Marty's parents fell in love at in 1955? This is a hard one.
It is a hard one. I remember there's something under the. Yeah, I have to pass on that one.
Oh, no. It was the Enchantment Under the Sea dance. You were close.
Yeah.
You were close. You're
Forgot that
just like Marty's sister who called it the Fish Under the Sea dance. You were
I
close.
remember
did a little
mostly his
research before
guitar
this.
piece on
Oh, yeah.
that party, I guess. Yeah, that was my
Where his
favorite
hands
part.
disappearing, right?
Yeah, and then
Boom.
playing the guitar. Yeah.
Okay. What does Biff get covered in all 3 Back to the Future movies? And he hates it.
Pretty much, well, I'm trying to find the proper word for it, but it's horse,
Manure. Horse
manure,
manure
yeah,
is
yeah,
what he's going to
exactly.
say.
Yeah,
He almost
exactly.
said shit, folks, but I'll say it for him.
Yeah,
Okay.
exactly.
All right. Last one. You're doing really well here, but this will give you at least a B. You'll get 4 out of 5.
All right.
How fast must DeLorean go to achieve time travel?
I believe 88 miles per hour.
88 miles per hour. You did really well, right? So
All right.
I think next time in DC, I think we need to do Back to the Future 1, 2, and 3. We'll just sit there, hang out, and watch all 3 movies. I want to thank Dr. Abron. That was a lot of fun. Love Back to the Future. And I got to learn a lot today. So great episode. And we'll catch you on the next episode of the All In Practice Growth Podcast.
Are you ready to go all in?
Let's do this. Let's do this. Let's do this.